Thanks, Presiding Officer. Today's statement coincides with the publication of the revised strategic framework for tackling COVID. So I will set out the key elements of the new framework and explain what it means for our collective response to COVID now and in the months ahead. At the heart of the framework is a desire for and increasing confidence in our ability to achieve a sustainable return to a normal way of life, even as we remain prepared for future threats that COVID may present. So I will start today by describing our updated strategic intent and approach. This new approach will see us resort much less, hopefully not at all, to legally imposed protective measures. Instead, we will rely predominantly on vaccines, treatments and sensible public health behaviours and adaptations. However, much as we might wish it was not the case, COVID is still a public health risk here and globally, and likely to remain so for the foreseeable future. So we must also remain vigilant and prepared. To that end, I will also outline how we will categorise and respond to future risks, including from new variants. And I will explain why our decisions must be based on a combination of data, evidence and judgment. Thirdly, I will give our assessment of the current situation in Scotland in light of recent data and set out an indicative timescale for lifting or converting to guidance the small number of legally binding measures that still remain in place. And finally, I will set out our commitment to continued access to PCR and lateral flow testing free of charge, while we transition to a system of testing that is more targeted but which retains adequate capacity to support surveillance, rapid response to the emergence of new variants, effective outbreak management and access to the best care and treatment for those who need it. And I'll also confirm our advice that those testing positive for COVID should continue to self-isolate for now. On the issue of testing, Presiding Officer, I must express frustration at the UK Government's position. It is, of course, for the Prime Minister to decide how best to tackle COVID in England. However, current funding arrangements mean that while taxpayers in all 4 UK nations contribute to the costs, it is decisions taken for England that determine the resources available to Scotland, Wales and Northern Ireland for testing and other COVID measures. As of now, we have no clarity on how much of the COVID testing infrastructure the UK Government intends to retain, no clarity on how much investment will support it in future, and no clarity on whether the Treasury will provide additional resources or demand instead that funding is taken from elsewhere in the health budget. I hope we do get this clarity soon so that we can then set out in more detail our own longer-term approach to testing. However, and I'll say more on this later, I want to give an assurance now that the Scottish Government is determined to retain a robust testing system capable of providing Scotland with strong resilience against future COVID threats and firmly aligned with public health advice and the principles underpinning our National Health Service. Let me turn now to the key points in detail, starting with our revised strategic approach. In earlier phases of the pandemic, it was important to try to eliminate COVID or suppress it to the lowest possible level, because then we did not have vaccines or treatments to protect against the serious illness and death that the virus can cause. That is why our objective initially was to suppress the virus to the lowest possible level, though we modified that somewhat last year. In today's update, it is modified further and now expressed as follows: to manage COVID effectively, primarily through adaptations and health measures that strengthen our resilience and recovery as we rebuild for a better future. This change is possible because widespread vaccination coverage and better treatments have reduced the direct harms of the virus. As a result, using restrictions to suppress infection is no longer as necessary as it once was, and given the wider harms caused by protective measures, it is no longer as justifiable either. The strategic framework, therefore, makes clear that in future we will seek to rely much less on legally imposed measures and more on vaccines, treatments and sensible adaptations and good public health behaviours. As a priority, we will continue to ensure the maximum possible availability and uptake of vaccination in line with expert advice. While the success of the vaccination programme has exceeded our expectations, there are today still more than 600,000 people over 18 who have had a second dose but not yet a third or booster dose. So there is more still to do to maximise uptake. We will also continue to extend the scope of vaccination. Last week, the JCVI recommended that all 5 to 11-year-olds, not just those at highest clinical risk, should be eligible for the vaccine. And I can confirm today that vaccine appointments for this age group will issue from mid-March. To allow parents and carers to attend with children, most appointments will be in the evenings, at weekends or during the Easter school holidays. Yesterday, we also accepted JCVI advice on protecting those at highest risk. It is now our intention to offer care home residents, those over 75 and anyone over 12 who is immunosuppressed, an additional booster 6 months after their last jab. This phase of the programme will also start in March, though the scheduling of appointments for individuals will depend on the timing of their initial booster or third dose. In addition to vaccination, we will also use the best available treatments for those who need them. There are already effective treatments available which reduce serious illness and death in those who have been admitted to hospital with COVID. Therapeutic medicines are also now being offered to patients who have not been hospitalised but who are assessed as being at greatest risk of needing hospital treatment. And new oral antiviral treatments are currently being evaluated through a UK-wide study. We will make the best use of those treatments depending on what the evidence and expert advice tells us about their efficacy. Vaccination and treatment will play a major, perhaps the major role in limiting the health harm caused by this virus in the months and indeed the years to come. However, it is also important to encourage and support people to adopt safe practices and to make basic adaptations that will help keep us safe. The document we are publishing today gives more detail on the kinds of behaviours and adaptations that will be encouraged in different circumstances. These include enhanced hygiene across the general population and improved ventilation in workplaces and other settings, and especially when levels of infection may be higher, increased hybrid and flexible working and the use of face coverings in some indoor public places. It is less likely that any of these measures will be legally imposed in future, but we will advise them for as long as they help keep the virus under control and also help protect those who are most vulnerable to it. It is also vital, of course, that we remain vigilant for new developments. It is, unfortunately, highly likely that this virus will continue to mutate and confront us with new and potentially more harmful variants in future. To identify and respond to such threats quickly, we will maintain a strong surveillance capability. We will set this out in more detail next month, but subject to the point I made earlier about the overall resources available to us, our surveillance system will include extensive PCR sampling and processing capacity, wastewater sampling and genomic sequencing capability. We also welcome confirmation that the UK-wide COVID infection survey conducted by the Office for National Statistics will continue. It is essential, however, that it continues at scale, and we will seek to work with the UK Government to ensure that this is the case. Presiding Officer, this surveillance capacity will help us identify new threats rapidly. It will also help us assess the potential severity of any new threat and quickly determine the appropriate level of response. The strategic update we are publishing today sets out a clear framework for any decisions we may have to take in future in response to new developments. I want to stress this is intended as a contingency. We do hope, of course, that we never have to use it. However, it does recognise the ongoing challenge that COVID presents and sets out 3 broad levels of future potential threat: low, medium and high. It also offers illustrative examples of the type of protective measures that could be deployed in response to different threat levels, and it may be helpful to illustrate this through some general examples. If a new variant emerged that was more transmissible and more severe, perhaps with the ability to evade vaccine or natural immunity, this threat would likely be classified as high. In those circumstances, we might advise people to limit social contacts for a period and to work from home where possible, and we may introduce some temporary protections for high-risk settings. If a new variant, though, was either more transmissible or more severe, but not both, as is the case with Omicron, the initial threat assessment would likely be medium. In these circumstances, there may be a legal requirement to wear face coverings in some settings, and we might issue guidance for businesses and service providers on reasonable measures to reduce the spread of COVID on their premises. Lastly, in the absence of a new variant, or if a new variant was neither more transmissible nor more severe, and if vaccines continue to be effective, the threat classification would likely remain low. Obviously, this is the level we hope to reach and stay at on a sustainable basis. In these circumstances, there would be no legally imposed protective measures. Instead, we would continue to advise individuals and organisations to adopt sensible public health behaviours. It is important to stress that any decision about the threat level and what the appropriate response should be will be guided by data and evidence, but it is not an exact science. It will also, by necessity, involve judgment. That is because the kind of developments we may face in future, principally new variants, will not be uniform in their potential impact. A new variant that is highly transmissible but less severe would obviously require a different response to one that was less transmissible but more severe. So we must guard against a one-size-fits-all approach. That's why the framework doesn't propose fixed thresholds for action, for example by stating that we will take certain predetermined steps if the number of cases rises above a specific level. Such thresholds may be superficially attractive because of the certainty they appear to provide, but they pose a very significant risk of both under- and overreaction. Now, the framework I have just described can be used to categorise our current threat level and therefore help guide decisions in the coming period, and I'll return to that shortly.